No, I watched some of them last night.
Okay, great. Wonderful. So, hello and welcome. My name is Mitch Sanders. I'm co-chair of the Wound Healing Society Communications Committee along with Kyle Quinn. It's my pleasure to host another WRR Fireside Chat for the Wound Healing Society. Today, we have a very special guest. He's Douglas Hamilton, who is an associate professor in the Department of Anatomy and Cell Biology at the Schulich School of Medicine and Dentistry, the University of Western Ontario in Canada. Doug, welcome.
Thank you. It's happy to be here.
So the paper we're covering today is the pig as a model system for investigating the recruitment and contribution of myofibroblasts in skin healing. And I think we'll have Mitch start with the questions.
Wonderful, Doug. So if we could start a little bit before we start with the paper, just to provide for the video audience, so the Wound Healing Society members, a little bit more about your background and where you did your PhD. I have a hint of a Scottish accent there, so that's not very...
There's a rather thick Scottish accent there, yes. So I did my undergrad at St Andrews because I was into golf, and then I did my PhD at the University of Glasgow with Professor Adam Curtis. Adam was a very interesting individual. He was as I found out subsequently, he was the first person to ever apply interference reflection microscopy to biological tissue. And he did he was a genius in all different areas. And I worked there on cartilage, and my PhD was sponsored by Smith and Nephew. So I did a sort of case award study, and it was my first introduction to really how to modulate cell adhesion. We worked on different cell types. From there, I ended up in Pittsburgh, and I spent 3 years at the McGowan Institute in Pittsburgh working for David Vorp, who was in vascular biomechanics. So I started to learn more about the effects of biomechanics on tissues and cells and things like that. Then I moved to UBC, University of British Columbia, and I spent 4 years there working for Don Burnett in the Faculty of Dentistry, looking at how essentially materials are integrated into the oral tissues. So basically my lab now, if I had to describe the overall research topic, it would be how do cells sense their surrounding environment, and how can we use that information to increase wound repair or understand more about wound healing processes. And we have a lot of focus on sort of adhesion mediated signaling and things like that, but we also have been doing a lot of work on wound chronicity and trying to understand chronic wounds. And that sort of comes from my time in the Vorp lab, where we used to go to amputations to get saphenous veins. And one of the things that always stuck in my head when we were at these amputations were the number of the limbs that had chronic ulcers or chronic wounds on them. And for some reason that stuck in my head. And when I moved here to Western, we started a program almost immediately looking at chronic wounds in humans. So that's sort of my background. We're interested in wound healing and biomaterials, basically.
It's funny because there's a lot of Canadians that have the name Doug Hamilton. So there's a famous rower, and then there's a bunch of hockey players that all have the name Doug Hamilton. So I was hoping that you're going to be a NFL hockey player, but impressive career nonetheless.
Yeah, no, I mean we do like hockey. Obviously, being in Canada is a sort of prerequisite, whether you're from here or not. You have to, but also being my background in Pittsburgh, I used to go to Penguins games, and I was very fortunate to be there when Mario came back in 2001. So I got to see Mario play and stuff. So I count myself very lucky.
So let's turn to the paper, and just so you know, my lab does a lot of preclinical porcine infection and wound healing models, and I was just delighted to see this paper because oftentimes I think about these, we're constantly doing these preclinical models for clients, and the tough thing is we don't publish enough of them. I think I have 2 papers I'm submitting this month, but oftentimes we do it to really understand the science or the mechanism of action before we can bring a product to market. So half the time I don't get to talk about it, but it's exciting that I have some papers being submitted. But let's start with the myofibroblasts and wound healing and the similarities and differences in humans and porcine, both the Yorkshire and the Duroc pig.
So, I actually learned a lot writing this paper. And I have to thank one of the reviewers. He or she knows who they are. They directed us in certain directions during the writing of the manuscript. And I think it's important to frame it in what do we know about humans and myofibroblasts and wound healing. Obviously, for most people should be aware, but the myofibroblast is, it comes in, it makes the granulation tissue, it secretes new matrix, it provides structure for the epithelium to migrate on, and they're also posited to contract the wound. When we went in to sort of say, well, what do we know about humans? We ended up going back as far as 1916 in this paper to Cottrell, I think it's Carell's work. And they showed way back, and also Hartwell's studies. And there's a lot of information in these papers about how humans heal, how they heal their skin wounds. And although they're not directly looking at myofibroblasts, they did implicate the subcutaneous fat as being an important source of cells for formation of the granulation tissue. But in terms of the myofibroblasts in humans, there's all the papers I'm going to mention are cited in our article, so people can get them in there. There was the Betts study in 1992 and Rosalind Butterworth's thesis, which they look at alpha SMA content in human wounds, and basically what can be taken from it is that it's highly variable between wounds of different ages. They can be seen as early as day 5. And they generally decline over time, but not necessarily. So it's kind of all over the place. But I think one of the biggest findings that there is, and it does go all the way back to the Carell paper, is that the presence of myofibroblasts in humans does not actually correlate that well with clinical contraction. And that's a big one. And obviously nowadays it's very hard for us to do human studies, or to get, to do temporal analysis of wound healing in a human is very difficult for ethical reasons. But, there's been other studies which, I wouldn't say they're contradictory, but, the study by Berry in 1998 on the sacrogeal sinus healing, they found that only about 10% of the cell volume was actually myofibroblasts. And the interesting thing is that they found that the myofibroblasts associated more with thick collagen fibers than thin collagen fibers. So there was a sort of certain distribution of them. But I think in humans, the general theory is, or the general hypothesis would be that they're there, is variable, and it doesn't correlate well with clinical contraction parameters. In the pigs, the problem is it does correlate really well with clinical contraction parameters. So the number of myofibroblasts in the pig is directly correlated with the level of contraction. So immediately we have a difference between the pig model and the humans. And this is also, obviously in the human and the wounds, there's different anatomical locations and things that we need to sort of control for. The Yorkshire pig, which is the model that we have experience with, the earliest time point we looked at was 7 days. We did find one study that I think showed myofibroblast present at about 4 days. In the studies that we've done, by day 7, the whole granulation tissue is just full of myofibroblasts. And it's very, very well developed at 7 days. And you do see quite a high level of contraction in the wounds even by day 7. These were 2 centimeter diameter wounds, full thickness, including removal of the fat, which is something I'll talk about later. But, the red Durocs are typically a model that's used for studying hypertrophic scarring. And the Yorkshire pig, when you look in the literature, is largely used for wound healing studies. So it kind of breaks down in that way. the interesting thing is that there's probably more known about the myofibroblast persistence in the Yorkshire pig than there is in the red Duroc, even although the red Duroc is the one associated with the scarring. And so it was things like this that sort of formulated the paper and how it ended up, like really comparing studies and asking. But in general, yes, baseline, there seems to be a difference between humans and pigs in terms of the myofibroblast content.
Can you talk a little bit about the need for standardization of these models? It seems like everybody does a different size wound, a different thickness wound, and it's very hard to compare the studies.
Yeah. So one of the things I'll say at the very beginning is that we kind of didn't really deal with burns because our reading of the literature sort of showed that the burns seem to be in a sort of different category. And I think a lot of the porcine models for pigs are really looking at split thickness grafting and how do we improve this and things like that. And I can see that there's a reasonable overlap probably between treating a burn on a pig and a human in terms of the techniques that are used. In the full and partial thickness wounds, as table 2 in the paper shows, it's very difficult to make comparisons between studies because we simply are not standardizing how we are doing the studies. And we're as guilty of this as anybody. I don't want people to think that I'm pointing fingers or anything like that. This is simply a sort of non-biased assessment, because when we did our first study in 2014, we went into the literature trying to find reasons for some of the things that we were seeing, and we found it very difficult to find the information. And I'll talk about one of them later on, but one of them was we saw differences in the amount of contraction dependent on where the wound was in the animal. And it wasn't related to any treatment that we had given to it. So there was things like that. I think there's a lot of things from a number of years ago that we haven't kept up on, or we are not applying to the standardization. But I think in general, because we use the pig for testing, treatments, therapeutics, we need that to be the variable between studies and not the location of the wound, the method of covering the wound, what is the environment of the wound. So there needs to be some level of standardization, I think, if we're going to make comparisons across studies. With the caveat that there is also veterinarian considerations. Our institution, there are things that the veterinarians won't let us do. And they do insist that the animals are, I can give one example, that we use buprenorphine as the analgesic, but the vets have told us that if they think the pig needs something additionally, they're going to use an NSAID. And so my response to that is, if you give it an NSAID, you have to give them all an NSAID. Right. So that we're standardizing it. So even within the protocol within your institution, you have to make sure that you and the veterinarians are on the same page.
Agreed. There's a lot of analgesics out there that will slow or speed up wound healing, and so you have to be very careful. Ibup is pretty good, and there's some others like Tramadol, I guess, is pretty good, but there's others that will dramatically affect wound healing, and then you really skew the study. The problem that I always have is every time I go back to the porcine model month by month, it's for a different indication of a device. And so I'm doing partial thickness, I'm doing full thickness, I'm doing punch biopsies, and I'm doing a serious dermatoming for certain things. And so it really is, what am I trying to study and what kind of endpoints do I want to get with the device to make sure that there's a good p-value for a paper or a positive outcome for the client. So oftentimes it's driven by what's in the literature. The other thing that you mentioned, which is really interesting, is a lot of, the folks at Johnson & Johnson now, I know they're not really into advanced wound healing anymore, but they were doing studies back in before 2000, and they had some great models, but they never published a lot of the models. So a lot of the models that we do for infection wound healing study in a porcine, nobody has a paper on it because we did it all internally for our work with Johnson Johnson. And
I remember speaking to one company, actually, I'm not going to name the company, but they have a living tissue skin equivalent that they use to test their products on, and it is better than anything that has ever been put out into the wound care marketplace, but they're not interested in it for that application.
Well, it's something we're doing in our lab, actually. We're 3D printing new tissues and getting a lot of human skin samples to do and try and get a more reproducible model also from a biofilm point of view. The problem with Greg Schultz has this great pig explant model for biofilm. They have to kind of, sometimes I like to lightly sterilize the tissue, whether it's E-beam or a little bit of autoclaving, just so that we can get the background down before we form a biofilm we're putting in there. So it's not such a but biofilms are polymicrobial anyway, but you'd like to start with what you're adding. Can you talk?
One of the things I would say is that I think sometimes in the papers that are published, the justification for the methodologies doesn't come out. So, people, we compare it in the paper about subcutaneous fat, right? Half the study, or about a third of the studies, say they've removed it. A third of the studies don't say whether they removed it or not. And a third of the studies didn't remove it. But when you read the studies, they don't tell you why.
There's like all of us, we're under a word limit, right? For more discussion or for more, and then oftentimes the animal studies are done offsite or with a independent group that may or not, those parameters don't get fleshed out. I think what needs to happen is one of these good wound care journals, if there was like a methods kind of thing where we could publish those things. I think that'd be really, maybe it's an added addition to wound repair and regeneration where we focus just on methods for preclinical and clinical methods. I think that would be ideal because there's a lot of, not folklore, but there's a lot of knowledge that's never transmitted to the paper, unfortunately. So, Kyle, do you want to ask a question or you want me to keep rolling?
I guess, no doubt that, standardization would be helpful. I guess, obviously it's hard to get consensus and, there's a lot of other factors, but, I'm curious whether if you're in charge of standardizing, porcine models and, for even just like full thickness wounds, I mean, what would your recommendations be for size, shape, adipose, no adipose, wound coverings? And I'm curious whether like you and Mitch could even agree on this.
So, yeah, it's fascinating. So basically, I think there was, one of the things that they showed in humans was that, and this goes back to the 1916 paper, was that the amount of contraction is relative to the size of the wound, such that different sized wounds in the same person would contract down relatively similarly in speed. I don't think that's ever been shown in the pig. Nobody has definitively shown that would occur in any of the pig models by doing multiple different sizes in the same animal. So I think that's something that would need to be done first before you could really standardize the models. And 2 centimeter wounds, diameter wounds, full thickness with the fat removed, heal extremely rapidly. They're closed completely within 28 days. And in the Yorkshire pig, you see virtually no scarring. It's a very, very rapid response. So it suggests that 2 centimeters may not be big enough. It might have to go larger than that. Then that cuts down how many wounds you can put per animal, because we have veterinarian, oversight on that. How many can we put in an animal? And so I think if I was going to try to standardize it, I think there are things I would want to do first. And, looking at wound size and correlating it with the amount of contraction based on the wound size, how long to closure. I think this is information that's definitely missing with regards to really saying that it's similar to humans. The other thing that I would bring back in again is this idea from Hartwell's paper that the granulation tissue really forms from the fat underneath the wound, and that the dermis is largely inert. They use the word it's inert, and we see this in our pig studies. We see no activation of the dermal structure at all. There's no fibroblasts in there that are proliferating at day 7, no obvious signs of it. So then it becomes a question of, do you leave the fat and do you remove the fat? Well, when we've removed the fat surrounding the uninjured dermis just migrates up. And when we isolate the skin, it looks like a volcano. You can actually see it with your naked eye. You see this volcano in the tissue. So I think we need to decide, and it's not that you could standardize it completely, I don't think, but I think justification for why you're looking at what you're looking for in the paper would be important. If you're leaving the fat in, why are you leaving the fat?
Yeah, that's why I think there needs to be, as they say, a journal just attributed to, this is what we recommend for a partial thickness wound, this we recommend for a full thickness wound. If you're doing an infection model, there's certain things that, nuances that you can do to get a nice brewing infection, and then be able to try and treat that and try and get it. But the difficulty that I have with the Yorkshire pigs, they want to heal so fast that it's you only have a very short window of 2 weeks of seeing a beautiful infection before the animal just says, no, I'm going to heal. I don't care. And there are some delayed healing models, but they suffer from, one is a glutaraldehyde model that some folks in Texas have. The problem there is it's still got a lot of glutaraldehyde that's then going to interact with your drug or anything that you're going to try and treat the infection. Then it's not a great model for looking at drugs, because the drugs will react with the glutaraldehyde that's freely just sitting up in the wound.
Yeah, I mean, one of the models that they talked about here at our school was a cauterization model. Was cauterizing the edge of the wound and around the epithelium to try to slow the healing down. But we were shocked when we did our first study. We've done 3 now. We're working towards publication of some more of the data. But we were shocked at how fast the control wounds closed. The ones with nothing in them.
No, that's why I like the porcine models for looking at the inflammatory and proliferative phases. But it's so fast, you don't get a lot of benefit at the later stages of tissue remodeling. The other thing I want to point out, and you probably know this as well, is the model for debridement in the pig, although it was kind of established by the people that developed Santil way back when, the Health Point folks. They have kind of a soft and a hard eschar model for debridement. It really is more of a scab. It's not really a great eschar. It's hard to mimic human eschar, the green slop or the really black crusty eschar. And so I actually cooked brisket, cut up burn ends, and figured out how to dissolve burn ends and use that as my model for debridement. Cooked 21 briskets of all things and figured out how to dissolve burn ends and I developed a drug based on it. It's almost like a meat tenderizer, if you will, and it does great but until we got it in patients, we didn't know how it was going to do, because the porcine models directionally looked like it was very good, but it's just not the same kind of eschar. These soft and hard eschar models in the pig is in the human, so it's a real challenge. But do you want to talk a little bit about? I think people may or may not realize this: how different the moist and dry environment in a wound bed can be, and how that changes the trajectory of healing.
Yeah, I mean, so obviously this comes back to some of the work that Winters did, but I mean, it's been known since the late 1800s that bathing wounds increases the rate of healing. It's not new information, but Winters did some studies in the 1960s with pigs and showed that you could get if you used a moist environment, you think they used polyurethanes or polyesters over the top of the wounds, that You got faster reepithelialization, faster granulation, tissue formation. Inflammation was modulated, and essentially it just gave a much healthier environment for the wound to heal in. There was less infection. And I think some of these in the pig, we've not carried this through. We're limited here in terms of the fact that the veterinarians insist on it. We have to cover the wounds. We don't get a choice. So by definition, we are using moist environments. I think in the dry environment, the eschar that forms in the pig, some studies have suggested it's very stiff. It prevents the epithelium from sort of migrating through it. But I think it's something, again, when you look at the porcine literature, some studies don't say whether they do it or not. Some studies do it for a certain amount of time, and it's not standardized across studies. And it does impact, I think there's a really nice review by Johan Juncker, where he talks about everything, and he looks at it from a clinical standpoint on the effects of it. But basically, it gives you a healthier healing, and the cellular effects that it's having. So I think it's something that we should be bringing in more and standardizing across models.
Yeah, our infection model, whether it's full or partial thickness, we'll just put a tegaderm covering on a thin film. We don't want it to be too moist. We want to slow down healing and keep the infection there as long as we can. And we're only able to we can get out to about 35 days with a nice brewing infection, at least for the first couple of weeks. By the third or fourth week, it's pretty much ready to heal. The other thing I want to talk about was you mentioned, and this is a really important point for people who do this study, is that even in different regions of the back of the pig, you get very different healing rates. And I always thought it was because I'm not dermatoming well by the scapula or the buttocks, but it may actually be more the biomechanical force or integrity of the tissue, and the thickness of the skin could be different in the different regions of the animal.
Yeah, I think we said in the paper, you can't consider the back of the animal to be a blank homogeneous canvas, because the skin is not the same thickness across even the dorsum. It's not the same thickness. And the myofibroblasts, which is obviously our focus, is they're associated with increased stiffness. We have knockout murine models where you get absolutely no myofibroblasts in the granulation tissue that forms, but even at the areas at the very edge, which are the areas of highest peak stiffness, they develop. So the stiffness is a really important factor to take into account, and the mechanical properties of the skin are obviously different if it's thicker. If you have a thicker dermis, the mechanics by definition are different. And I think there's a paper which I think needs to be, everybody who's doing a pig study needs to go and read this paper. And it was by Catherine O'Brien in 2015. She works with Wei Lee, I think, and David Woodley when she was publishing the paper. But they tried to reassess where on the animal you could make the wounds and see similar rates of healing. And basically what they showed is that they did an analysis of the tissue, and what they showed is that when you come from the middle of the dorsum and down the side of the animal, it increases in, there's a decrease in compliance, right? Or sorry, not compliance, I always get this wrong. Basically it becomes more compliant. The skin itself becomes more compliant. And they got it to the point where they showed that if you're doing a test treatment on one side of the animal, if you want to mimic it properly, the control has to be in exactly the same position on the other side of the animal. And a lot of people are making the wounds on the back, down the midline of the animal. We immediately saw that anything close to the scapula healed faster. We've seen that in all our studies. It heals way faster, which makes sense that the animal is moving. Between its shoulder blades, it's stretching the skin, and it has a big impact. So I think we need to look very carefully at where we're making the wounds, because the mechanics are different. There's been studies, and we actually found this out from not the healing literature, but we actually got it from needles. testing how much force does it take to push a needle through the skin. And they showed, like in the scalp, for example, in the pig versus the human, there was a twofold difference in the elastic moduli. That's huge. That's a really big difference.
There's the reason why we make footballs out of pigskin. I mean, the force break modulus for pigskin is unreal.
To me, though, that was very interesting that we're talking about a twofold difference in the elastic modulus, which is a material property, right? So it's not, in theory, that's independent of thickness, too. So, I mean, what do you think's going on there? Are we talking about differences between the epidermis, or, I mean, is there vastly different collagen fiber organization or density there, between the two species in the same location?
I don't think anybody's ever looked.
Or is this just a lack of standardization in mechanical testing, and some of the challenges and assumptions associated with that?
I mean, we found it very hard to get any mechanical assessment of the pig skin. There's really not that much of it being done. There's probably more in the human literature. But, anywhere, if you make, there was one study that showed that across the wound, there was a difference in stiffness, but it didn't necessarily impact on the presence of blasts. So I think there is work to be done in understanding it more.
We actually do a lot of biomechanical testing of tissue after it's healed, especially in mice, but also in pigs. And I can tell you that when we do the pig measurements, you have to use a 200 Newton device, a different load cell, right? And with the mice or rats, you probably can get away with a 50 Newton load cell. So there's a huge difference in the integrity of the tissue. But you're right, it's one of those things that oftentimes it never gets published, or it's not characterized enough. So
we're obviously interested in it because we're interested in myofibroblasts, and we're interested in stiffness. And I think, just to link back to it, what Boris showed with his paper in Nature Biomedical Engineering with the breast implants is, if we hold a breast implant, we sort of think it's fairly compliant, but a cell doesn't. It doesn't see it that way. It sees it as very stiff. And so there's what we think a compliance is versus how a cell interprets the signal. And that's one of the things we're interested in. We do a lot of studies with dermal fibroblasts and materials of different compliances to see at what point the cell will or won't turn on alpha SMA. And it's variable. It is variable, but I think in general, we need to look at studies like, by O'Brien and really look at where they're making the wounds and why they're making them there. And if we can start to standardize this, I think it would have a big impact on treatments.
So Kyle's you're an editor of Wound Repair and Regeneration, right? You're on the
I'm on the board, but
yeah. So poke at them and tell them that we should do standard methods in wound healing. It would save a lot of PhDs a lot of time, so that they could actually do the study right the first time, because there's so much input that we could provide. I've been doing porcine models before my kids were born, so it goes back like 30 years now, right? But a lot of it we don't talk about what we do very much or very well.
And I think this was one of the things that we found out when we first did the study, was that we were sort of a little naive, I guess, is one way of putting it, when we did it. And we sort of thought, we'll bring them in, and the vets do everything for us. We're not allowed to do it, right? So in one hand, you're kind of hands-offish on it. But now that we've talked to the vets and they've seen some of the results, the vets are actually listed on the paper. Emily Truscott is one that we're still working with here at Western. And they're interested in understanding more about the wound healing, right? Because one of the things that they were, the vet told me, she's taught that the skin, it heals side to side. And I said to her, well, what if it heals top to, bottom to top and not side to side? And she's like, well, I wasn't told that. And so, it's challenging, these ideas that maybe we need to look at, specific things in the wounding to understand more about human wounding. Because, I mean, like I said, one of our main areas of interest is wound chronicity. And it is very hard to mimic in an animal model. I mean, I know there are some nice studies.
Yeah, so just to point there, I do think that some of the diabetic rats, the BBZDR or the Zucker, are so fat that they're under a lot of tension. So they don't contract like a regular rat would contract, you know? And so it's under so much tension that if you punch biopsy the tissue too far, the animal it'll just spill out its organs. It's under so much tension, you know? And the diabetic mouse model, the benefit there is there's so many studies on the diabetic mouse that you can make some comparisons. And when you see differences in healing of, you know, twofold or threefold, or you beat the positive control, the classic PDGF, TNF alpha, or whatever it is, it's obvious that you have something special. But how does that translate to humans? That's yet another story, right?
Yeah, and when I speak to the surgeons that we work with, you know, I've been told, you know, where chronic wounds are concerned, sometimes they have to throw the kitchen sink at it to try to get it closed, and that's not very scientific, you know. And I think that's, you know, it's a big problem for them. One of the things that one of the other surgeons told me was that the problem that they face is when they go into the clinical literature and then they look at the exclusion and inclusion criteria for a lot of studies, their response is, but I have to deal with the patient I have in front of me. I don't get the luxury of inclusion and exclusion criteria. So
yeah, very clear that real world evidence for wound healing is very, very important. Now, that said, in order to have an effective drug study or a device study, you have to do those kinds of things, or you're not going to get p-values that are going to be meaningful. You're not going to see a positive endpoint. So the oftentimes we skew studies in the clinic and even in preclinical models so that we can understand better what's really going on in a simpler case, if you will. And so, you know, when you're in the clinic and you're studying VLUs, once they're a certain size and they're infected, they're not going to heal. And so that's an interesting model to study, an interesting way to look at certain things that can stop the infection, then start the healing process, right? But it's not, every wound is different. It has a different chronogenicity. And, you know, there's different levels of senescence. You know, we like to think of diabetic foot ulcers or just senescent fibroblasts, but there's so many other things going on there than just senescent fibroblasts that it's hard to translate that into every patient's wound. That's why, you know, you look at some of the healing rates, 12 weeks for devices like negative pressure, and the numbers look amazing until you just look at really chronic wounds, and then the numbers are 47% or 45%. It's a totally different world, right? Just to kind of finish up, I thought your paper is wonderful. I think a lot of people are going to cite this paper because it's as a scientist, does a lot of preclinical research, and we study anything from qPCR to biomechanics of tissue and pulling it apart. There's such a scarcity of literature, but you pieced it all, what was there, you pieced it all together and provided just a great story and something that every student in my lab will have to read before they do a preclinical study. So I think you did a wonderful job. Kyle, any other comments before we try and wrap up?
No, I mean, I think what I'm getting from this is there needs to be a workshop at a conference where we just get everyone together and agree on some of these things.
I'm recommending Hawaii or I don't know, somewhere really nice. But
the reason I totally agree with you. I said this to my wife the other night. There needs to be some kind of symposium where you bring together all the people that have done huge amounts of work on PEGs, way more than I've done, and discuss it. You know, and if this paper ends up being, you know, something that can help facilitate that, I think you know, it's.
Yeah, sorry, my son's dog is home from Chicago, so he's here. No, I think it's a wonderful idea, and it's almost like a consensus paper around best methods for preclinical practice, which I think would be a great series, and could be a could be a conference, could also be, as I say, a special journal for WRR, and I think it'd be cited all the time because it's hard to piecemeal how these studies are done, and there's so little information in many of them that you have to kind of piecemeal it with 7 different papers. And so I think it's a great idea.
I'll give you one little example before we go. So we did, for other reasons at our institution, they were doing streptozotis and induction of type 1 diabetes in pigs. And they had about a 50% mortality rate with it. And they discovered there was another group that had done it, and they talked to the other group, how are you doing this? And when they explained how they were doing it, they were making the streptozotisin up in their lab and then walking it to the animal facility, which took about half an hour. And our group making the streptozotisin up in the OR room and then directly injecting it into the animal. Like, it's got a half-life of 10 minutes. So the concentrations that they were injecting were completely different.
Wow.
And so I think these types of things only come from symposia or, discussions. And I think I would have loved it when we started doing pig studies, if I could go and download a paper and say, if you're interested in assessing full thickness wounds, here is a methodology that you should follow. It would have been amazing. It would have been absolutely amazing.
I think, I don't know if Kyle has been on the program committee recently, but I'm on almost every year for the Wound Healing Society. So we'll certainly bring it up and try and feature it for next year's, not next year's meeting's already planned, but the following year meeting would be a great time to put this on the agenda and have a focus session. And I'll sponsor the beer for that one. I think it'll be awesome. Anyway, Doug, it's a real pleasure meeting you. Thank you for joining us for this edition of Fireside Chat. I have 3 more videos to edit, and so I hope to have these up in just after Thanksgiving. And I'll send you an email to notify you that it's posted up on the website.
Thank you very much for asking me to do this, and I hope you both have a wonderful Thanksgiving.
Real pleasure, and happy Thanksgiving to all.
Happy Thanksgiving. Thanks.
Thanks a lot.